Hello, this is Dr. Mendes to finalize the chromatic code in the test. So we're still in the previous lecture. Now we are going to briefly discuss how testicular occurs developmentally. So the test said they develop in the abdomen, but eventually they descend before into the scrotum. So the scrotal swelling will appear at 7 weeks in the lower wall. So we have called processus vaginalis, which is just an vagination of the peritoneum. So processus vaginalis will evaginate from the peritoneum and push into the swellings. And you have this of the abdominal muscle and fascia forming the cover of the spermatic cord, and also the abdominal muscles giving rise to the inguinal canal. So all this happened during development. The test develop on the posterior abdominal wall, the urogenital, which remember they are mesodermal in origin, and the germ cells come from the yolk sac. So the testes develop in the posterior abdominal wall, the kidneys on the urogenital ridge. Then we have what we call gubernaculum testis, which is just a ligament that connects testis and epididymis to the inside of the scrotum. The gubernaculum testis ligament that connects testis and the epididymis inside the scrotum. So as the scrotum is grown, it pulls the testis, epididymis, and gubernaculum posterior and inferiorly. The testes are initially retroperitoneal, then they travel linearly and exit through the inguinal canal into the scrotum. So from the abdomen just below the kidneys, they move peritoneally, the deep inguinal ring to the inguinal canal, then to the superficial ring into the scrotum. So the gubernaculum testis now becomes the scrotal ligament. So the testis actually pulls the spermatic cord along with and towards the processus vaginalis, pinches off to form tunica vaginalis. And tunica vaginalis now has two layers. Remember, it's processus vaginalis with peritoneal evagination forms tunica vaginalis. So it will have a visceral that covers testis and the epididymis, and the parietal layer that really folds back gives a hilus, the hilus onward. So this just shows what happens during testis descent. So the testes are initially in the abdomen, but they descend through the ring, superficial ring, we enter into the scrotum. So in this, the scrotal swelling just started, develop, and there is a gubernaculum connecting the scrotum to the developing testis. So what happens? The gubernaculum sort of pulls downwards the testis to come from the abdominal wall through abdomen, retroperitoneal abdomen, through inguinal canal towards the scrotum. And if you look at this region, the spermatic has been formed, the gubernaculum has reached in length, and the testes are now settled within the scrotum. So anomalies associated testis, you can have hernias, inguinal hernias. We have indirect hernia. Remember we said indirect hernias occur lateral to the Hasselbalch's triangle. That means the lateral herniation occurs from the lateral aspects of the inferior pituitary vessels through the deep ring, through the canal to the superficial ring. So this indirect is mainly in children, and it results from persistent processus vaginalis when it's to close at birth. So the processus vaginalis is peritoneum, is a potential space that allows loop of bowel, greater momentum to the scrotum. So they will herniate from the abdomen through processus vaginalis scrotum, and eventually this can lead to strangulation and bowel obstruction. And we also have peritoneal cysts. When you have this peritoneum cavity persisting, you can form cysts in this, and this may be noticeable at birth. Accumulation of fluid in this peritoneum can to hydrocele. So hydrocele is when you accumulate fluid in the scrotum, the peritoneal membranes. Testicular torsion can occur. The testis twists over the spermatic cord. So when you have that twisting, you have to obstruct the blood vessel. So it can lead to necrosis of it when there is torsion of the testis. So this is what we call testicular torsion. This is the normal testis, and here there is torsion of the parts of spermatic cord, so the testicular vessels are occluded. Then there is inguinal, which we have discussed, direct one. It's mainly the congenital inguinal hernia. So we said when processus vaginalis persists or fails to close prior to birth, and you get the bowels and the omentum herniating through deep ring, canal, the superficial ring into the scrotum. We have what we call vasil. So the pampiniform venous that drain the testis. So when this vein become dilated and tortuous. Yeah, they form mucocils. So these are actually palpable and they feel like a bag of worms. So this shows the venous plexus. So when they become dilated and tortuous, they will feel like a bag of worms inside the scrotum. Then we have torquidism. Torquidism is when the testis fails to descend birth. So by birth, it's supposed to be in the scrotum. When it fails to descend, you can have torquidism. So it occurs on one side, it's less potent, but if it occurs both sides, then the man will be sterile. Spermatogenesis cannot occur when the testis is in the abdomen because the temperatures are too high. Testis are supposed to be in the scrotum. Temperatures are lower than the body temperature. That helps the spermatogenesis to occur appropriately. So if the testes are in the abdomen, it will lead to sterility. Sperms cannot be produced. So the testes can descend but remain in the inguinal. So again, surgery will be needed to bring them down to the scrotum. More often, when the testis is at an abnormal position in cryptorchidism, either the abdomen or the inguinal canal, they are predisposed to cancer, testicular cancer. So usually the testes are supposed to descend in the first year of life. If they fail, a surgery has to be performed to bring them to the scrotum. So ectopic testis is just a testis not in the scrotum. It's not in the usual place. So it has probably in the abdomen or it's in the inguinal canal or in the thigh or in the So we have what we call matosil. Within the peritoneal membranes in the scrotum, if you accumulate blood, that's what we call hematosil. If you accumulate fluid, we call it hydrocele. So hematocele is accumulation of blood made in the tunica vaginalis and it can occur after trauma. Briefly, on the prostate, the prostate is actually attached inferiorly to the urinary bladder by ligaments. So you have the prostate located posterior to the symphysis and it surrounds the superior part of the urethra. It surrounds the prostate urethra. The prostate is located anterior to the rectum. So when you do digital rectal exam, put your finger through the anal canal and the rectum. Anteriorly, finger can palpate the prostate. If you do digital rectal ultrasound, you put ultrasound probe the rectum, you can see the prostate anterior to the rectum. So the prostate is a conical organ. It's located below the urinary bladder, posterior to the pubic symphysis, and anterior to the rectum. It's around prostatic urethra. So it's walnut size, measuring 4 by 3 centimeters, and it's encapsulated. So you have fibrous tissue, smooth muscle, and smooth muscle within the gland. So the prostate gland is actually a highly fibromuscular gland. So you have the glandular portion, which is compound tubular, but you also fibromuscular portion. So a lot of fibrous tissue and smooth muscle. Now, it has a capsule that sends in septatide the gland into lobe. So the prostate gland is the largest male accessory reproductive gland. It's a large accessory reproductive gland and it's located in the subperitoneal compartment. So it's between the pelvic diaphragm and the peritoneum. It's enclosed in fascial sheath. So inferiorly, the sheath is continuous with the superior fascia of the urogenital diaphragm. The sheath of the prostate is continuous with the superior fascia of the urogenital diaphragm inferiorly, and posteriorly forms part of the rectal cycle septum. Septum is posterior to the bladder. So the prostate has a double capsule. So you have a first portion that contacts the gland and an external capsule that is usually formed with the pelvic fascia. So there is a venous plexus that lies in between the double capsule, an outer fibrous and an external capsule by pelvic fascia. So this prostate gland, we said, is a walnut conical shape below the urinary bladder. It surrounds the prostatic urethra. It's anterior to the pubic symphysis and anterior to the rectum. So there's a base and an apex. So this is the base, this is the apex, and it also has surfaces. So it has posterior surface, anterior surface, and inferolateral surfaces. So posterior surface is close to the rectum, anterior surface is towards the pubic symphysis, and the lateral surfaces on the left side. So the base is attached to the neck of the urinary bladder. So this is the bladder, and the prostate is attached there. The base of prostate. The prostatic urethra enters the middle of the base close to the anterior surface. This is the base. In the middle of the base, you have the prostatic urethra from the bladder. So remember, this prostatic urethra contains opening of the ejaculatory duct. Ejaculatory duct brings it from the testis through the vas deferens. So ejaculatory duct is for the union of vas deferens and seminal vesicle. So contents of seminal vesicle ejaculate from the testis will be emptied in the prostatic urethra through ejaculatory duct. So again, this is the prostate, the urinary bladder, the prostatic urethra. You can appreciate that the rectum is posterior to the prostate and the pubic space is anterior to, and this is the difference that will be distance from the testis, epididymis, vas deferens, inguinal canal, posterior to the bladder. Vas deferens with seminal vesicle will form ejaculatory that will open into the prostatic urethra. The apex of the prostate is inferiorly located, so it rests on the superfascia of the urogenital diaphragm, and the apex is associated with the sphincter of the urethra. The apex prostate contacts the medial margins of levator ani muscle. The posterior face is triangular in fact, while the anterior surface is narrow. Inferior surfaces, you have the right and the left side, the right on the levator ani of the genital diaphragm. So the prostate has different lobes, two lateral lobes, one median lobe, anterior and posterior lobe. So two lateral lobes, one median lobe, anterior and posterior lobe. Where are these lobes located? So median lobe is posterior to the prostatic utricle and the ejaculatory duct, and it may project into the urinary bladder. You have the utricle that lies within the mid lobe, and this utricle is vestigial of the uterine homologue. So the median lobe is posterior to the ejaculatory duct. Then the lateral lobes, you have right and the left side, they have the largest of the gland and secretory tissue. Glandular portion of the gland is on the lateral. So the prostate is supplied by arteries, internal pudendal, inferior vesicle, and middle rectal artery. They give branches that will supply the prostate, and it is a venous plexus in its capsules that will drain to internal iliac veins, which communicate with vesicle superior vein plexuses. Lymphatics from the prostate, where do they go? To the internal iliac, okay, and sacral nodes, and posterior to the external nodes, which are not palpable. So the pit has 30 to 50 gland elements, which are compound tubular glands. The prostate empties through prostate urethra via ejaculatory. So the secretions of the prostate are thin, milky, and alkaline, and are during ejaculation. So the prostate urethra makes part of the semen. So the size of the prostate is small at birth and enlarging puberty, and progressive enlargement 40, which is associated with benign prostate hyperplasia. Sometimes the prostate may actually undergo atrophy. So benign prostatic hyperplasia affects approximately 90% of men above 50 years. This diagram, this is prostate, okay, and it's enlarged the urinary bladder. Then prostatic cancer is common, a very cancer in the male. So as you can see, this portion has been affected by prostatic cancer, this median lobe. And in this image, this is where benign hyperplasia occurs. Okay, so when it occurs at the region close to the prostatic urethra, so usually it is obstruction of urine. So cancer of the prostate gland can metastasize through blood, through lymph, hematogenous and lymphogenous metastasis respectively, and metastasis can get to the vertebrae, to the pelvis, through the venous plexus. So through prostatic venous plexuses, it will communicate with external vertebral plexuses. That's how it will spread vertebra into the spine, and it can also spread the pelvis directly. Ascites is inflammation of the prostate. Yeah, it could be caused by transmitted infections or urinary tract infections. So it can be treated with antibiotics and massage of the prostate through digital rectal exam. So prostatitis, painful urination, and some back pain. The prostatic lesions, we've already talked about them, but we also have prostatic concretions, corpora amnesia. So increase with age and may become calcified. They usually simulate carcinoma. So corpora amnesia are just ellipses in the prostate that increase with age. They may be calcified and fused for cancer. So this one shows you how to palpate the prostate in digital exam. You put a finger through the rectum and palpate the prostate annually. Thank you very much.